Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of the optometry field through dynamic insights, practical clinical tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in eye care. Our mission is clear: empower eye care providers with the knowledge and tools needed to provide exceptional patient care. At Advanced Patient Care, we are dedicated to elevating eye care one episode at a time.
I'm Dr. Zach Keenum. I'm an oculoplastic surgeon at Vance Thompson Vision in Sioux Falls, South Dakota. And I'm here with Dr. Risfet today, and we're going to talk about oculoplastic surgery, what it is, what it involves, what kind of surgeries we do. We're going to look at it from kind of the patient side of things. So what to expect as a patient, what to counsel patients on if you are an eye care provider, but maybe you don't provide oculoplastic surgery as a service. We're going to kind of go into all that so you get a really good grasp of just what the specialty is, who it's for, and how to kind of educate patients around it and some of the new things coming along in oculoplastic surgery.
I love that, Zach. And I'm Deb Risfit. I'm from Alexandria, Minnesota, Vance Thompson Vision. And I'm just so excited, Zach, just to have a conversation today about, something that we're super passionate about. Zach, there's a lot of people that don't know what the term oculoplastics entails. Can you kind of give a rundown of what the specialty involves? What
Yeah.
kind of surgeries are you doing every day? What kind of patients do you see?
Right. Yeah. So oculoplastic surgery is really just plastic surgery around the eye. So it essentially focuses on plastic surgery in this area. It does branch out into the face a little bit in some circumstances. And we'll also do things like orbital surgery, tear duct surgery, that kind of thing. But by and large, 85+% of what we're doing is eyelid surgery, both functional, meaning for helping patients function better in their daily lives, but also cosmetic and aesthetically in this area. And so we're primarily seeing patients that either have issues with their vision due to heavy upper eyelids, or the eyelids are rolling in or rolling out or causing them issues for some reason, in which case we may need to do reconstructive procedures. But a lot of what we do also is for aesthetics and cosmetics. So that side of oculoplastic surgery has seen a shift to the younger population, especially in recent years, and a lot of that probably owes to COVID and everybody getting on Zoom and seeing themselves in cameras that are facing back at them and seeing their eyes and that kind of thing. So that's most of what we do. But to go back a little bit, oculoplastic surgery is typically something that's done after ophthalmology training. So Deb, you and I are both ophthalmologists by training, and then we have kind of further pursued doing a little more in-depth work in just eyelid surgery. And so that's really what oculoplastic surgery is.
Yeah, and that's beautiful. And, a lot of people that come to us are referred in from their primary eye care provider. And so, what are the things that we're looking for as, comprehensive ophthalmologists or in the optometric community to say, I think that this patient would be a good candidate for eyelid surgery?
Yeah, that's a good question. And this is something that I actually went through personally through training. So when we're in ophthalmology residency, a lot of times we're in these situations where patients have very significant eye pathology, a lot of really severe diabetic retinopathy and tractional retinal detachments, and, some really severe things that maybe you don't see as much in private practice anymore. But one of the things I realized was that we just weren't looking at patients' eyelids. We were really just trying to get to the heart of what was their really severe problem that was limiting their vision. And so it wasn't until I really got into fellowship that I learned to look at people from that way and look at their eyelids and their facial structure and actually all of it and how it works in harmony with their face. So that took, I would say, about 6 months to learn to see a patient in that way. And it was something that I really, really focused hard on. And during training, I watched the people that I trained with about how they looked at patients. And I would look at what surgeries they were signing up certain patients for. And one trick that I even found in training was I would go look and see, just based off a patient's photo, what I thought that they needed surgically. Then I would look in the notes and see what my attendings had decided they needed. And that helped train my brain. So before I get too much into all of that, is that kind of like, was that your experience as well, Deb, or?
Yeah, that's beautiful. And, I always tell patients and colleagues, some of it is a science and some of oculoplastics is an art. And that's why we love it. You and I, Zach, share a love for painting. We like to use our creativity. And so, that's really important, to look beyond, just the pathology of the globe. And, one thing I've found out, being a comprehensive, I focus on cataract, refractive cataract, glaucoma, and oculoplastics. And so what I'm seeing is that we see a lot of pathology of the lid from these other disease processes, whether it's from long-term glaucoma medications or if they've had multiple surgeries, they come in because the levator muscle is stretched. And so they get ptosis that we have to repair down the road. And
Mhm.
so, a lot of things that are done, just surgically in ophthalmology sometimes end with needing an oculoplastic specialist to really get them to see fully. Say cataract surgery, we're getting them to see better and more clearly, but guess what they're noticing? They're noticing that their side vision is gone from droopy eyelids. And so that's where, Dr. Keenum, you come in to really evaluate this patient. And one of the things that you brought up was, the change after COVID, we're going on Zoom and we're seeing our face in a different way. We're looking in the mirror differently than we used to. And so younger patients are starting to come in. So, is it too early to have, say, an eyelid procedure? And when does insurance kick in? So, when do we have a functional case where we need to remove droopy eyelid skin that insurance will pay for versus it being cosmetic?
Yeah, that's a good question. Yeah, it's something that people ask us every day, I think, when they come in, is my insurance going to cover this or not? And so there's tests that we can do in office that are relatively quick. We'll do visual field testing on patients to see if they qualify through insurance. So we'll have patients do visual field testing, then take their eyelids out of the way and see if their field of vision, their superior field of vision improves. And that can be an indicator to the insurance companies that by doing a surgery like a blepharoplasty or sometimes brow lift or ptosis surgery, that their vision will improve and therefore there is a functional reason to do the surgery. Some of the other things we look at are the distance between their line of sight or their central vision and their lid margin. These are some of the things that the insurance companies look at. And if patients aren't candidates, we're able to tell them that. A lot of times the surgery can still be helpful cosmetically, and so we can still offer that to patients. But that's kind of how we go about evaluating them and seeing if they're going to qualify. And it's not always something that you can just tell from looking, in your office, in your optometry clinic. So if you're not sure, you can send them and we can do the testing and let them know, and they'll know before surgery whether or not they're going to qualify, so there's no surprises.
And I love that. And I always like to follow, there's a dry eye paper put out by ASCRS that talks about look, lift, push, and pull. And I think that's brilliant for oculoplastics. You want to turn on the lights. You want to look at the patient's face, from the forehead down to the chin to kind of look at their anatomy and see, if they have changes, in their musculature, if they have changes in their bony structure, if they have changes, maybe in the way that one side is versus the other. So I always like to kind of note some asymmetry. I also like to kind of push on the eyelid to say, okay, a lot of these patients that we're doing eyelid surgery on have dry eye, and so we don't want to make their dry eye worse with doing any type of procedure. And so we're looking at the meibomian glands. We're making sure that they have enough tear film to really protect the cornea and the globe. Lift, there's not just droopy eyelid skin that we see. There's brow ptosis. There's muscle droop from maybe a chronic eye rubber or someone that's used contact lenses for a long time. And so that's where we're kind of pulling and lifting and trying to figure out, is it coming from just the excess eyelid skin, or do we need to address the brow? Do we need to address the muscle? Do we need to tighten the lid? And that's where pulling comes in. When we pull on the eyelid, it should snap back. And so we're assessing not only the upper lids, but we're looking at the lower lids, even if that's not their complaint, because a lot of these patients that come in have a poor snapback test, it's called, where you pull down on the eyelid and it doesn't resume correct anatomic position. And so those are patients that you also can address the lower lids at the same time as the uppers. And a lot of times, as you probe and ask questions, they do say, oh, yeah, I have tearing down my cheek all the time. Well, anatomically, their lid is probably not in the correct position. And so these are all things that we look at when we're evaluating patients. But, just to kind of note that, a lot of people don't realize how much it's impacting their lives. Would you agree with that, Zach?
Yeah, absolutely. And I think you bring up a good point that it is a multi-part problem, especially with the uppers and the droopiness. It's typically brow, lid position, and then skin, those three things. And so often we're looking at doing blepharoplasty combined with ptosis and sometimes combined with brow lifting. And I'll typically do all of that at once if needed. And the other part of it is that it's a dynamic system. So sometimes fixing one thing may worsen the other. So sometimes patients will have mild amounts of ptosis that if you correct it in office with phenylephrine or even mechanically with your finger, you can actually see their frontalis and brow drive decrease. And so it can be an indication that you're going to need to either add brow lifting into the surgery or maybe just forgo the ptosis surgery altogether if it's mild to begin with. So we're addressing all of these things with surgery often. It's not uncommon that I'm doing a blepharoplasty, ptosis, brow lift, and then, like you said, also addressing the lowers. So that poor snapback is pretty common in our older patient population, and you really do need a tight lower eyelid for the tear pump function of the lid to work. So the way that the tears move across the eye to the tear system is by having a tight lid that when you blink pushes the tears across and actually mechanically move them. And weak lower eyelids or ectropion or mild ectropion will make that such that it doesn't work. And one of the things that we'll also combine it with even our younger patient population, even with the mildest amounts of lower lid laxity, for things like lower blepharoplasty, I'll combine lower lid tightening. So I've been doing a lot of canthal suspension techniques and canthopexy techniques where we don't necessarily open up the lateral commissure completely, but things to tighten the lower eyelids with lower blepharoplasty to prevent what's probably the most dreaded complication of a lower blepharoplasty, which is lower lid retraction, where you get a pulling down of the lower lid or a rounding of the lateral canthal angle, where patients lose that almond shape or that nice, well-defined acute angle to their lateral canthus. And so I've been combining a lot of those techniques with the lower bleph patients as well.
Yeah, and that's beautiful. And, we talk about, a lot of these things, say excess eyelid skin being kind of a non-urgent situation. But, what are things that you're looking for in your office when it comes to managing oculoplastic patients that could turn into an urgent situation?
Yeah, so I would say probably what's one of the more urgent things for us from a lid surgery standpoint is, patients with either like facial nerve paralysis with like a Bell's palsy, that kind of thing where they can't close their eye. I did a surgery like that just a week and a half ago now, where, patient tries to close their eye, it stays completely open. So that poses risk to the cornea. And so we want to act a little bit more urgently. It's not, next day kind of thing, but so getting a gold weight in, doing an ectropion repair, a little small tarsorrhaphy, that kind of thing can help. The other thing that we push a little bit on from a time standpoint is entropion. So when patients have frank entropion and they have a lot of lash cornea rubbing, that can be dangerous to the cornea. And so we'll try to do those surgeries a little sooner. We can sometimes temporize with Botox in the orbicularis to weaken that orbic override and kind of temporarily take the entropion away. But I would say those are some of the things that are a little bit more urgent from an
Yeah,
oculoplastic standpoint.
that's beautiful. And knowing the anatomy is so important, Zach, because when it comes to, even thinking about maybe orbital tumors,
Mhm.
could you kind of expand on that? We have two fat pads in the upper lids, and we have three fat pads in the lower lids. And so, a lot of times that pushing or putting your hands on the patient, if they have some fullness, can really help you to get a sense of if there's anything else going on. And so, not only are we protecting the health of the eye, but we're also looking for things that maybe don't belong. And so, what are some of those things, Zach, that we're looking for when it comes to, possible orbital tumors that could be missed?
Yeah, that's a good question. So like you said, pushing on the eye can be very helpful. So one of the things that I used to do in fellowship a lot and still do from time to time is I'll take both thumbs and put them on the patient's closed eyes and just feel the difference in the sort of the compliance of the orbit. So it's called a resistance to retropulsion. Sometimes you can feel a resistance on one side versus the other. If you think about the orbit, it's essentially a fat compartment. So you can think of it like a ball or like a marble sitting in jelly. And if you push that marble, it should give quite a bit. And if there's resistance to that, it starts to tip you off that there may be something in the closed orbit that is causing that resistance. So that's one thing that when we're pushing on the eye. The other thing that you can do is a quick and simple kind of poor man's Hertel. If you'll have a patient lean their head back and look from underneath, you get what's called a worm's eye view, and you can see differences in proptosis or axial displacement of the globe. So if one eye is in front of the other from something like a tumor that's pushing it forward, or thyroid eye disease can do this as well. You can a lot of times see that difference with your naked eye without needing Hertels or anything like that. And then the other thing that you're probably going to pick up on in the optometry clinic if a patient has an orbital tumor might be something like displacement of the globe. So again, thinking of the orbit as a closed, confined space, it doesn't have a lot of room for extra things. So if you add a tumor in there, it's going to push the eye in the opposite direction. So, if we have a supranasal tumor, we might see the eye move down and out. We might see difficulty with eye movements or restriction in certain directions of gaze. And then the other thing that you can see is refractive changes. So if you have a patient that's having very large degrees of refractive changes over a shorter period of time, or even not so short period of time, depending on what's growing in the orbit, that can be an indication. So if there's a tumor behind the eye that's compressing the eye in its axial dimension, it's going to shorten the eye, and you may get a hyperopic shift. Whereas if you get something pushing on the side of the globe, it can actually lengthen the eye and cause a myopic shift. So that can be something that can actually tip you off as well. And I've seen patients like that actually presented with these refractive changes. But
And I think that's what my point was. It's not always, functional versus cosmetic. Sometimes we have to explore and doing extraocular motility, checking their pupils to make sure they don't have any difference between the two eyes as far as that goes. Other things that we're looking at is extraocular motility, like you mentioned, as well as pupil function. We're looking for a nisocoria that could indicate, ptosis, meiosis. We've all learned about Horner syndrome. And so those are some of the things that we're looking at, as well as lacrimal tumors. I've caught a few of those where it looks like they just have fullness, and you actually palpate and you can feel a mass. And so those are the, things that we're looking for beyond just functional, kind of anatomy, looking at how the forehead moves, looking at how the eye muscles move. We're actually making sure that, the globes are where they should be and in proper orientation. We've kind of covered the functional when patients are covered by insurance, but Zach, let's go into the aesthetic component of oculoplastics. It is an art, and there's so much that goes on in the face, in addition to just droopy eyelids. And so touch on kind of new technology or new techniques that you're seeing when it comes to cosmetic and aesthetics.
yeah, it really is an art. Deb, you're absolutely right. And so a lot of times what we find ourselves doing with the patient on the table is I'll often do this is just stand up and look at what we've done, and then just making a true artistic judgment on what's going on. So, you learn in fellowship and in training how to do the technical side of things. You learn how to remove fat, you learn how to put the canthus here and to do the techniques, but it takes one level up from that to be able to actually look at it and say, is this pretty? Is this appealing? And so that's something that takes time to learn, and it's just doing a lot of surgery is where it comes. But yeah, I would say that, cosmetic surgery is a very exciting area to me because of that artistic side of it. Like you said, you and I both like to paint, and we have an artistic side. And so it's fun to get to try to essentially take a very technical skill and use it through an artistic lens. It's an interesting thing to do. And if you asked about kind of the changes that have occurred and the things that are coming down the line with cosmetic surgery, it really is kind of blowing up right now. You know, the number of these cosmetic surgeries are increasing every year. And some of the things that I see, I find the history of these things pretty interesting, but lower blepharoplasty in particular, because as you and I know, upper blepharoplasty and lower blepharoplasty are just two different beasts altogether. The lower
Yep.
blepharoplasty is far more technically difficult. A lot of plastic surgeons won't touch it. Just because of that and the problems that you can get with it. And like you said, it comes back to knowing the anatomy and being really comfortable around the eye, especially with lower blepharoplasty. But a lot of the shifts I've seen, over time is that, when lower blepharoplasty was done many years ago on the order of decades, it was primarily done from the outside through the skin, and this is still done. But people realize with time that there's increased risk of scarring when you go through these multi-manipulated planes. So going through the middle lamellar or septal plane, you're going to get more scarring and this lid retraction. And so what people started doing was going through a transconjunctival approach, where we actually go from the back side of the eyelid and are able to access the fat pads from the back of the eyelid, and then we can do with them what we want, whether it's reposition them into the tear trough, hollow, reduce them, whatever we want to do. But that was found to be a safer approach to prevent lower lid retraction and also offered the benefit of not causing a scar, which is really nice. So that was one shift that kind of, I would say the general oculoplastics community primarily uses that approach. There's actually literature on this that I think it's over 90% of oculoplastic surgeons prefer a transconjunctival approach for lower blepharoplasty. But what I've noticed in more recent times is probably over the last, I would say like maybe 5 to 7 years, is people are starting to really address not just the lids, but really kind of look at the whole mid face when they're doing lower blepharoplasty. So something that's becoming very popular over the last few years is autologous fat transfer to the mid face to build up the mid face, to build up the tear troughs. And so that's something that I'm seeing incorporated into a lot more cosmetic surgery, is not just focusing on the lid, but building up the periocular adnexal structure around it to make it a more harmonious blend into the face. And so that's something that's coming along. And then also incorporating lasers into our cosmetic surgery. So you and I both do this. We both love our lasers. We just not too long ago
Yes.
got a CO2 laser, which I was very excited about. And so to me, all of these things are additive. So addressing the fat, addressing minute amounts of skin with skin pinching, tightening the
Yep.
canthal ligaments, doing the laser resurfacing, all of those things add a little bit that when combined really give you the best cosmetic result. And so that's kind of where I see things going right now, is combining all of these little things to give a nice result and trying to be as minimally invasive as possible. Is that kind of your general
Oh,
gestalt around it?
that was beautiful, Zach, because
Thanks,
it
Jess.
is so true. We just don't appreciate that in residency. We're so involved in the, kind of technical piece of surgery, like you talked about. But really, if you sit back, what happens in our 30s is we start to actually have bony change. And in our 30s, every decade we lose elastin and we lose collagen in our face. Our muscles become more atrophied over time. And so really you could do the perfect lower lid blepharoplasty or even upper lid blepharoplasty. But if you're not looking at the mid face, especially, to build that up, they're just not going to be as satisfied, especially if they're coming in for a cosmetic procedure. And so, that's where our passion in looking at the skin and reducing wrinkles and brown spots, so age spots, are possible now to do in the operating room. And so even if they have a functional blepharoplasty of the upper lid, we can still do laser resurfacing to get rid of the perioral wrinkles, to reduce some of, the age spots, to decrease the vasculature on the cheeks, like rosacea, which in turns helps their dry eye. And so that's where Zach and I have become so passionate about really integrating these different procedures for the best results. And then you talk about, what you can do post-operatively after you've had, a cosmetic or functional procedure. And there's things that we can do in the office, whether it's, neuromodulators, where we're actually using Botox or Dysport or Xeomin. There's tons of different, neurotoxins that can help reduce some of these fine lines and wrinkles that are caused by those dynamic muscles in the forehead and around the eyes. We can also do fillers that help build up the cheek or help stretch the chin for patients that, are bothered by their jowls to avoid a facelift. And then we can continue doing laser resurfacing or laser rejuvenation right in the clinic to really maintain their skin and to build collagen over time. And so that's what I love about oculoplastics. It's not just like a one and done procedure. We can actually do things right in our office to really maintain and to delay that aging effect that we see over time.
Yeah, that's a really good point. And to that effect, we can do some of these surgeries in the office too, even. So a lot of the upper blepharoplasties that we're doing on, some of our younger, more healthy patients that want to be in and out quick, 30 minutes, go home, not have a lot of to do and fuss and in the operating room. We can do some of these in the clinic, and I'll actually do quite a few of those in clinic, and patients seem to really like it, and we're able to do it under just our oral sedation with our melt, same as we use for our cataract surgery patients, and then a little local anesthetic, and they do really well.
Yeah, and I think that people want that and they want to get back to their normal life as quickly as possible. When we talk about post-operative course, obviously it depends on what we're doing and what surgical procedure they have. But Zach, kind of walk us through what your typical post-op course is looking like for some of these eyelid patients.
Yeah, so I think this is probably the most important thing to patients, like you said, Deb. It's how quickly can they get back to doing their normal life and how long are they going to be bruised and swollen? This is the thing on the top of most people's mind and how much discomfort goes along with the whole process. And so kind of my general breakdown for patients goes kind of like this. I'll just tell them, this surgery, depending on what it is going to take about X long, upper bleph, 30 minutes. If we're adding a lower bleph, maybe another hour and a half or so. We're going to do patients under kind of a twilight sedation oftentimes, so they're breathing on their own. They're not having to have a tube down. They get to be awake for surgery, just relaxed and comfortable and not caring. And then we have our local anesthetic, of course. They're going to go home that day, so there's no staying overnight or anything like that. I tell them they're going to need a ride on the day of surgery because they're not going to be able to drive because they're going to be a little loopy from the anesthesia. But then they're going to go home. I like to have them essentially just take it easy. I tell patients, take it easy for a week. Don't do any heavy lifting, which I specify to them as try not to be picking up more than 10 to 15 pounds. Try not to be bending at your waist. Try not to be straining a lot. Anything that's going to increase the blood pressure to your head that may promote bleeding, which we don't want, I tell them to avoid. So light activity, going on walks. They can go on drives after, after the day of surgery if they feel like it. Things are going to be a little bit blurry if we're using ointments and that kind of thing. The eyes might feel a little bit dry right after surgery. That typically goes away as the orbicularis muscle wakes up. I warn them of that. We give them artificial tears, but we have ways to, during surgery to make sure they're not going to develop permanent dry eye by doing skin pinching and that kind of thing to make sure they're not going to have lagophthalmos. But I tell them about a week of easy life. The bruising and swelling, I tell patients, may last a week or two. It depends. If you'll be more aggressive doing the ice and the cold compresses, it'll go away faster. So what I have patients do is for the first 3 days, 20 minutes out of every hour while awake, I have them ice. And so I will tell them, if you're awake, sitting around watching TV, take your ice pack, 20 minutes on, 40 minutes off every hour while you're awake. It's a lot of icing, but I find that the patients that do it bruise and swell far less than the patients that don't. And I think they appreciate that at the 1 week visit. I'll have them come back at the 1 week and we'll take out sutures. I'll typically use non-absorbing sutures because I feel like it heals better. It's less inflammatory to the skin. It tends to, I think, give a little bit nicer results. And so especially in our cosmetic patients, we want that. But we'll get those sutures out at 1 week. And then I let patients go back to doing their normal life. So after that 1 week visit, I say you can go back to doing your normal stuff, no restrictions, maybe ease back into really heavy working out if you're into that kind of thing. But otherwise, you can pretty much do all your normal stuff after a week. The only thing I don't like patients to jump right back into is going underwater. So submerging your head in pools, hot tubs, and lakes. I ask them to try to avoid it for a month if they can. You can get weird atypical mycobacterial infections in the wounds from fresh water. And I let them shower, but I try to have them not do a lot of swimming for that first month or so. But other than that, it's essentially a week of taking it easy, having some itchy eyelids, and then they're back to doing their normal stuff. The bruising and swelling will tend to fade over that second week. If we've paired a laser with the surgery, like a cosmetic surgery, I find that has faded on most patients by about 7 to 10 days. It depends on how aggressive we're going with the laser, but with the CO2 laser, it's the redness and pinkness is mostly gone. By that 1 week visit, there'll be a little residual that goes away over the next few days. Um, Most of my upper bleph patients, we don't use any antibiotic ointment. I find you don't need it. I think you and I use a similar technique with a running subcuticular suture with steri
Yeah.
strips, so I don't need ointment. They, don't have the risk of allergic reactions to erythromycin and that kind of thing. It's one less thing for them to do. The infection rate with this is exceedingly low because of how well the eyelids are vascularized, and how well it heals. And so infections are very very low risk with these surgeries. They're possible, but very treatable if they do happen. So that's kind of the general picture I try to give to patients. If I'm really want somebody that's not getting, the extent of the bruising and swelling, I say, you may have a black eye for a week or two. People bruise differently. That's normally in our older patients. I find our younger patients heal much quicker. And then sometimes at 1 week, it looks like they haven't even had anything done in terms of the bruising and swelling they have. But that's kind of what I give patients to expect. Is that kind of similar for you or?
I love that. And you and I have, that subcuticular running stitch down where, it's actually one long suture of proline in the uppers and even the lowers, that you can actually pull out at 1 week. Sometimes we'll put in safety sutures, just to make sure if they rub the eye or if they took off the steri strip accidentally and the whole proline suture came with it. We're trying to safeguard against that. But for the most part, patients tolerate that type of technique a little bit better, because it's easier to remove instead of taking out stitch by stitch as far as a single interrupted stitch. And then, as Zach alluded to, it's really at 1 week they can go back to normal activity. But another thing I would add to where I'm a stickler for a couple weeks is makeup, directly on the eye itself, because they still have an incision there, and so we want to make sure that that incision heals. Scars are different in everyone, and we always ask, how do you heal? Have you ever had prior surgeries? Did you develop any bumpy scars or thick scars? Because I really like to know that beforehand, just so that we can really keep up on how they're going to heal. But a scar can take up to a year to fade, and so I'm really asking them to avoid sun exposure, to wear their sunglasses, to wear a hat, just to protect that scar. And then at a week, remember, we're taking off the stereo strips. And so at a week, they ask, okay, what else can I use to help with the scar? And so there's scar recovery gel that they can put on, as well as vitamin E. Do you have any other recommendations, Zach, for scars?
Yeah, no, I think that you bring up a good point with the scarring because that's also on everybody's mind is how is it going to heal. Fortunately, the eyelids heal fantastically, and I think this again goes back to the blood supply being very good one, but also it being the thinnest skin in the body. It tends to heal beautifully. Brow skin is, of course, less forgiving. It's thicker. It can scar worse, but the lids tend to heal fantastically. And I'll tell patients that ask about or are worried about scars, you can't make an incision on the skin without there being a scar, so to speak, but oftentimes they heal so well that they become imperceptible. And sometimes even at a week, it's hard for us to really make out a horrible scar. And I think that a lot of that owes to that technique with the running subcuticular suture. I find we get a lot less inclusion cysts and a lot less of that bumpiness along the incision line with it. If it does happen or patients really want to just, go at it with something, I think, like you said, vitamin E oil is good. And then there's a good gel called just Scar Away Gel. And you can buy it over the counter at most pharmacies for $13. It's made for other parts of the body, so it comes on a big roller ball. It's not great for the eyelids, so what I'll tell patients to do is just cut the back of the tube off, use a Q-tip, put it on twice a day, and then saran wrap the back of the tube so it doesn't dry out. It's 100% silicone gel, which is what's been shown clinically to be the best for scars. It's cheaper too. We have other options that are much more expensive. I tell patients, just go get this. It's cheaper. It's going to work, the best. So that's what I'll have them do most of the time is Scar Away Gel, vitamin E oil. And then, like you said, staying out of the sun. The sun can hyperpigment scars or hypopigment them and change the colors they heal. So avoiding the sun to the incisions is good. And then especially if we've done laser, that's going to be extra important. But yeah, I find that the lid incisions just heal fantastically for the most part. Like you said, it can take months to a year for them to heal. But if patients, are having a little bit of bumpiness or don't like the look, we can also do resurfacing laser along the scars to kind of help them along the healing process sometimes. So we'll occasionally do that as well. I know you do that some too, I think.
Yeah, I love that. And even if they just want a little touch up or, a little extra tightening, sometimes we don't have to go back and, take more skin. There's only so much skin that you can take of the upper lid and the lower lid that can cause more harm than good when we're talking about leg ophthalmos and talking about ectropion and beyond. And so we have to be careful about that. And my attendings always said it's better to be conservative than overly aggressive. You can always go back and take more. And I think, Zach, we get pretty good about knowing how much skin to take, and we have again some rules of thumb that we use to stay within those confines. But, everyone's different. And, that's where we just really want to follow these patients to make sure that they're recovering well, especially, if we're doing multiple procedures on the eyelid. It's really important, like Zach, you mentioned, sometimes it can unmask or uncover another problem. And that's so true with ptosis. Sometimes, you sit the patient up in surgery and it looks just absolutely perfect. And then a month later, or even a week later, they have some asymmetry. And so sometimes it's like a teeter-totter effect, or sometimes you don't get that perfect, contour of the eyelid. And so those are things that we really want to look at. So if some of your patients are not happy, we need to know about that, because again, it's so important when someone looks in the mirror to make sure that they're happy with their results, that they feel symmetric. It's kind of beauty is in the eye of the beholder. And sometimes they'll point out things that, we don't see. And so it's just so good to collaborate and, to take care of these problems early.
Yeah, exactly. You bring up a good point about ptosis, Deb. It really is probably the hardest thing I would say with what we do, other than just really artistically getting a lower bleph right, is ptosis. It's a very complex problem, and there's more moving parts to just going in, lifting a lid, and it being in the right spot. There's getting the contour and the shape of the lid right. Patients will notice contour changes far more than they will be bothered by height abnormalities. And the other thing that really bothers them is asymmetry. So patients, by and large, would rather be ptotic on both sides a little bit rather than be fairly open with slight asymmetries. Asymmetries are really what bother patients the most. And unfortunately, like you said, there's other things that go into it, like Herring's reflex, where you lift one eyelid, the other will come down. So these little micro changes can be from inputs to the brain on where the lid position will end up. And like you said, we can look great on the table week one. It can look low at week one or perfect, and it can change over the course of the next few weeks. And so it can sometimes take going back and tweaking things just a little bit. I will work with patients and try to get them to a good spot. If we need to go back and adjust something, we can do it. And ptosis is where that sometimes becomes necessary, because it's just such a tricky and finicky thing to get right.
Yeah. And Zach, I so appreciate your heart. And, that's one thing, we just want to do the right thing. And we want to make sure that, we provide our expertise and that we're there, if patients need additional hand holding. But, it's just such a fun field. And I really hope that you all have enjoyed this last kind of segment and this last podcast. about all things eyelids. And we just so appreciate you all. And please reach out if you have any questions.
Yeah, it's been fun. Want more? Schedule your personalized mini fellowship at Vance Thompson Vision today. Immerse yourself in hands-on learning, gain insights from our experts, and take the next step toward excellence in eye care. Remember, the world of eye care is ever evolving, and so are we.